Yes.
Are you in this section, this section, or?
Well, I'll introduce you, and then Good morning, everyone. Thank you so much for coming out, all you diehards, on the last day of the conference, and welcome to Visceral Vascular Imaging. We've got 4 great talks for you today. I'm Ian Kirkpatrick from the University of Manitoba, one of your co-moderators, and I want to introduce you to Dr. Daniel Vargas, who will be introducing the speakers. Welcome.
Thank you, and thank you for being here. Pretty big crowd for our last day. All right, so the first speaker of this session is Dr. Rebecca Rocco, and she's going to be talking about pelvic venous disorders. Just so you know, so that they can see your arrow, you have to move it to that screen.
Okay. Oh, this is the wrong talk. We're going to be in trouble if I did that. That's for my next talk. Oh, crap.
Is it loaded?
Do you want to switch positions, and I can give mine? Will you?
Yes, let's do that.
See if they can fix that out for you.
Change your plans.
Yeah, no worries. All right. Well, again, thanks for coming out. My name's Ian Kirkpatrick, and I'm going to be speaking about mesenteric ischemia. So we're going to talk about the pathophysiology of different types of ischemia, the CT signs, the things you absolutely do not want to miss, and how to optimize your protocols. So if we look at the causes of acute mesenteric ischemia, about 30 to 40% of cases are related to arterial emboli versus 20 to 30% related to primary arterial thrombosis. Now that's usually on a background of pre-existing atherosclerotic disease. Non-occlusive or low-flow ischemia, like a shock state, that accounts for about 20 to 30% of cases, and then the minority are related to venous thrombosis, that's about 5 to 10%. So let's look at what happens in these different types of ischemia, starting with arterial inflow ischemia. So that's your embolus, thrombus, or low-flow state. So something is stopping red blood cells from getting to the bowel wall. So before you have any bowel changes whatsoever, you do have potentially a chance to make a diagnosis by directly visualizing whatever is causing the blood flow to not get to the bowel wall, and that's with your CT angiogram. So what we're looking for on the CTA are direct evidence of mesenteric emboli or thrombosis, or the CTA findings of non-occlusive ischemia. A lot of us are less familiar with those, but they are an SMA diameter of 4 millimeters or less, impaired filling of mesenteric branches, narrowing of mesenteric branch origins, or spasm or beating of the mesenteric arcade, and we're going to see some examples of those in just a second. I like to take the data set myself and manipulate it real time, spin it around. The lateral view is really nice for looking at the origins of the celiac and the SMA. Thick MIPS are very useful for seeing the entirety of the SMA arcade, although you can't just use thick MIPS because you could potentially dial away pathology. If you have partially occlusive thrombus, you might not see it with a thick MIPS, so you need to thicken and thin it out. And again, we're looking for things like occlusions, emboli, or evidence of non-occlusive ischemia. So I have a few examples here. The patient on the left with the white borders, you can see they've got very few SMA branches opacifying on that AP projection, and on the lateral film, the celiac is really spasmed. The patient on the right has an SMA that's only 2 millimeters. So just by that, it's a little pinprick, you know that something's up. And in that case, there was such bad ischemia that air was dissecting through the mesenteric venules shown by that blue arrow. Now this next case has all of the hallmark findings of non-occlusive ischemia. So their SMA was 3 millimeters. They have impaired filling of their mesenteric branches. If you look at this volume rendered image, there's essentially no branches of the SMA opacified at all. There's narrowing of mesenteric branch origins. That's a very common place for the vasospasm to be the worst and more focal. And then there's beating of the arcade, which is often best visualized on volume rendered images. And that's again related to vasospasm. So it is important to always be looking at CTAs so you recognize when things that should be there just aren't there, such as in this example where we just are not seeing enough branches, the splenic artery is just way too small. Okay, so let's say we don't get our chance to diagnose the ischemia before there are any bowel changes. The first bowel changes that do occur is an ischemic ileus develops and there's dilatation, and the wall becomes hypoenhancing because red cells with the iodine we've given aren't getting there. So the dilatation is not super helpful, but hypoenhancement is a key early finding that we need to be on the lookout for. But it's hard to see because at this point the bowel wall is thin, and a thin bowel wall is one that is pretty difficult to assess. So it's important to try and find bowel loops that you feel confident are normal and have some iodine in them. So in this case, you can see on the right, we've got some loops shown by the yellow arrow, clearly normal. And then in contrast, you appreciate now that those loops on the left shown by the blue arrows do not have the same level of enhancement. Another case here where in the pelvis on the right, we have some normal loops shown by the yellow arrows. And in this case, there is mesenteric edema, so it leads our eye to these loops in the mid-pelvis, shown by the blue arrows, that are relatively hypoenhancing. Now again, this is a very specific finding, but it's actually not so sensitive in the literature because it's difficult to appreciate if the wall is hypoenhancing or not when the wall is so thin, especially if your technique isn't really optimized for that. Now, at this same time, you might see solid organ infarction because the same processes that are infarcting the bowel are also doing it to solid organs in many cases. Here we've got hepatic, splenic, and renal infarct shown by the yellow arrows and a coexistent embolus in the SMA. Statistically, if you see solid organ infarcts in someone with clinical suspicion of mesenteric ischemia, extremely highly associated, so that it's very likely they also have intestinal ischemia, but it's not 100%. So you can't just see a solid organ infarct and say, well, they also have mesenteric ischemia, but you should strongly consider that possibility and look very hard. So as the ischemia progresses and becomes transmural, because it starts mucosal, works its way out, you'll eventually get fluid seeping out from the bowel. That gives you mesenteric edema and then ascites. So you might think, well, that's pretty nonspecific and not super helpful. But again, I alluded to earlier that edema can lead your eye to loops of bowel that are in that zone, and then potentially you may see other more specific findings such as hypoenhancement or pneumatosis, as we see here. Eventually, the mucosa will break down. That lets air into the bowel wall and gives you pneumatosis. That air then gets into the mesenteric and portal venous system, and eventually you may see perforation. And in someone with, again, the clinical suspicion of acute mesenteric ischemia, seeing pneumatosis or mesenteric or portal venous gas is incredibly specific. But again, you have to have that clinical suspicion, so we're talking about symptomatic people only. Okay, so let's say we manage to reverse the arterial inflow ischemic process before the bowel dies. So maybe we do an embolectomy or we resuscitate somebody. We get what's called the reperfusion phase. So the bowel now has suffered an ischemic insult, cytokines have been released, and they increase the blood flow to the bowel and increase the iodine, so the wall thickens and becomes hyperenhancing. Now, this is actually potentially confusing because the bowel now looks like any infectious or inflammatory process, so how do you know this is reperfusion ischemia? Well, of course, you might have clinical history. So in this case, we had an SMA embolus at presentation, and you can see the blue arrow showing us hypoenhancing loops in the pelvis. There was an embolectomy, flow was nicely reestablished, and then we've got this mild thickening, hyperenhancement of those same loops. That is classic reperfusion, but we don't always have the luxury of having this kind of previous studies or good clinical history. So then we're looking for other items in the shock abdomen complex. Now, starting with the bowel wall changes, I did mention hyperenhancement, but be aware that you may see hypoenhancement as well because sometimes the bowel is just too far gone and it will not recover. Arterial vasospasm, very helpful because after an ischemic event, even if someone's resuscitated, the vasospasm will persist sometimes for hours. So you may see the CTA findings of non-occlusive ischemia even after somebody's been resuscitated. Hyperenhancing adrenals are a great finding. The gallbladder might be edematous. You might see mucosal hyperenhancement or periportal edema. You might see signs of ischemic pancreatitis, and solid organs generally may be heterogeneously enhancing or frankly infarcted. So here's an example. This patient came in after a TVAR septic. So they had a CTA first just to make sure the TVAR was okay. It was. And you can see just how beautifully we see all the branches of the mesenteric vasculature there on the left. Now, 24 hours later, the sepsis progressed. It was diagnosed as urosepsis. They were put on antibiotics, but they weren't doing well. Blood pressure started dropping. They got put on pressors. They're in the ICU. and now they've got worsening abdominal pain and rising lactate. So a repeat study was done, and you can see that on the right. You don't need any other images to know what's going on here. So we're not seeing any branches of the SMA. The splenic artery is barely visible. Everything is clamped right down. So clearly this person has diffuse vasospasm, and they've got non-occlusive ischemia. But we did do other images, and you can see here this patient has periportal edema, hyper-enhancing adrenals, their spleen is infarcting, they've got gallbladder wall thickening, their liver is infarcting, they've got ischemic pancreatitis. The orange arrow is showing some bowel loops that have the reperfusion appearance, but there's also loops in the pelvis that are not enhancing at all, and those were dead. The patient ultimately died, but this patient had, all of these findings we were just talking about. Okay, so let's go back to a normal bowel loop. Now we're looking at venous thrombosis, because this is quite different. So if we occlude the venous outflow, here congestion is a key early finding, and we see wall thickening right away, where this was not a prominent finding of arterial inflow ischemia unless we're talking about reperfusion. Now, if you have some venous outflow, you will get hyperenhancement of the wall, because iodine gets in and it has trouble getting out. If the venous outflow is completely occluded, then you start getting problems with arterial inflow, and you may see hypoenhancement. So you may see hypo or hyperenhancement, but the wall thickening is the big thing. So here the SMV is thrombosed, and early on we get quite a bit of wall thickening. Wall thickening, way more than we would typically see in arterial inflow ischemia. And again, you may see hyperenhancement or hypoenhancement, so be aware of that. It's all dependent on how bad the thrombus is. So basically what we've done here is we've described 3 different base patterns of ischemia. We've got the arterial inflow ischemia, the low flow state non-occlusive ischemia, which typically we see as reperfusion, because most of these people don't come to us when they're unstable. They come after they've been stabilized and resuscitated, and then venous ischemia. And what I want to highlight here is that the vascular findings and the wall enhancement, these are some of the earliest findings you will see and some of the most specific findings, and probably are the ones you should be focusing on. So look at your CTA, and then the question is, how do we optimize our ability to see this wall hypoenhancement? Because I told you earlier that the sensitivity is mediocre in the literature, and that's where our protocols come in. So if we look at our abdominal timing diagram for protocols, there's a number of different phases, and what we want to do here is scan in the enteric phase, because that's where the normal bowel wall is enhancing the most. So by doing that, we're going to make the normal bowel bright, and the brighter we can make it, the easier it's going to see easier it will be to see when it's not bright. But we also need a CTA. So you need to have a long contrast bolus, and you basically do a combined enteric arterial phase and get your CTA off that phase, and then a venous phase where you look for your venous thrombosis or solid organ infarcts. So enteric phase is about 45 to 50 seconds after injection, or 25 to 30 seconds after arterial peak. We give either no oral contrast or water, and we also do that first phase either with dual energy with virtual low monoenergetic KV reconstructions or optimum contrast reconstructions, or a low KVP, like 100 being the max and 80 being nice. Now, this is our injection nomogram. We do weight-based contrast dosing. Feel free to take a picture if you want, or I'm happy to email this to anybody. My email address will be at the end of the presentation. It's a lot of contrast, but we can modify it if a patient has renal dysfunction. And this is what these scans look like. This is someone who's relatively skinny, so it's quite pronounced, but this person had no positive oral contrast. This is just iodine that we've injected in the veins, making these small bowel loops this white. And this person had an SMA embolus. You can follow the green arrows and see that abrupt occlusion. And then the loops peripheral to that are extremely easy to see as hypoenhancing because we've cranked up the iodine conspicuity so high. Another case here, this patient had bad pre-existing disease, aortoiliac occlusion, but they came in with acute thrombus of their SMA on pre-existing atherosclerosis. They've got this thickened terminal ileum, and I think somebody had wondered if maybe it was an enteritis, but if you look closely at that blue arrow, there's this patchy hypoenhancement there that tells you it's actually ischemia. Their pain had been going on for a while at this point. And if you look at how white the liver is on the bottom left, you can appreciate how much we've cranked up the brightness of the iodine by using optimum contrast dual energy reconstruction combined with this injection protocol. We've really cranked it up so we can see subtle changes like this. This next patient is over 400 pounds, And you can see really nicely their normal enhancing bowel on the right, shown by the yellow arrows. They also had a shower of emboli, shown by the green arrows, a splenic infarct. And then these multiple other loops are hypoenhancing, and obviously so, even in a very large patient, because we've really sort of optimized this protocol to look specifically for this hypoenhancement. So we're not doing, a routine portal phase with a regular CTA here. So in conclusion then, hopefully the key points I want you to take away from this is please do not neglect your CTA, it's really important, and look for that hypoenhancement and do everything you can to stack the deck in your favor by making your protocols optimized to get that hypoenhancement as visible as possible. My email is there. Feel free to email me if you want any further information about this, and I really thank you for your attention.
Thank you for that wonderful talk. Now we're going to try again and see if we can get your Dr. Racco's talk. Let's see.
Yes.
Yeah, there we go.
I love RSNA. Okay, so we will get you this talk today. Just out of curiosity, how many people are international? That's what I thought. I figured that's the Thursday crowd. Well, thank you for staying. All right, so let's get started, and thank you very much for inviting me to present today. This is a topic that I think is really important and where we need to still do a lot more advancement. Okay, we'll talk a little bit about the background of pelvic venous disorders and then get straight to the cases. Yes, this is a trigger word right now for some people when we say pelvic congestive syndromes, and I'm going to talk about it a little bit. There's over the last few years, we're changing from saying pelvic congestion to saying pelvic venous disorders. And it's sort of a politically correct thing to do, I guess, because we don't want to describe pelvic pain as a syndrome, but rather that there are causes and it's a disorder. So we're trying to transition from syndromes to actually things that we can diagnose and treat and go from there. But forgive me if there's some change in terminology throughout, but I'll explain it. The older papers before 2021 are going to refer to pelvic congestion syndrome, and the papers after 2021 refer to pelvic venous disorders, and that's sort of the change, and I'll talk about that as we go along, because that's an important thing to take back to your own institute and to teach others. Congestive and compressive causes of pelvic congestion and pelvic venous disorders includes pelvic venous insufficiency due to gonadal reflux, the Nutcracker syndrome, Nutcracker, May-Thurner, POTS, and then other causes of mass compression, thrombus, or vascular atresia or malformations. Pelvic and scrotal varices, it's not just a problem in women. 10% of the population has varices, and a subset is present with pain and symptoms. For pelvic venous insufficiency, it's usually associated with premenopausal multiparous pain worsens with standing, and it's more often pain in one leg than the other, in the left leg than the right. So this is kind of interesting because a lot of these symptoms resolve after menopause, which is like one of the few things that I've been taught that's a good thing about menopause so far. And it's because it's related, a lot of these symptoms and the vascular issues are related to the hormonal status. So progesterone causes some issues with the valves and the veins not dilating, not working as well, and some insufficiency. And then estrogen can make pain receptors more sensitive. So that's why not everybody that has the imaging findings necessarily have the symptoms, because it's not just the imaging findings, there's a correlation to the actual hormonal status in the patient that goes along with the causes of pain. And I think that's important to take into account. Usually when I dictate a report and I see dilated vessels, I will say can be correlated with pelvic venous disorders, but not necessarily correlate clinically. The patient has to have symptoms to go along with the findings. So there are associations: polycystic ovaries, retroverted uterus, other varicose veins in the body, patient having multiple pregnancies. And then, of course, there are other causes of pelvic pain that need to be evaluated as possible causes and not just dismissed. including endometriosis, adenomyosis, UTIs, irritable bowel disease, and orthopedic conditions. So just to go through the anatomy and remember that the left gonadal vein drains into the left renal vein while the right gonadal vein drains directly into the IVC. You have the uterine vessels also draining, and then the plexus as well. So specifically here, when you have the superior mesenteric artery compressing the left renal vein, this is associated with the nutcracker syndrome and can be a cause of pelvic varices. And then here, for May Thurner, you can have the right common iliac artery compressing the left common iliac vein and also a cause of pelvic varices. So this is the new terminology paper that came out. There was a consensus paper in the Journal of Vascular Surgery that described this new classification system called SVP. It's not, it's 2021, so it's relatively new, all things being relative. And the most important, I think, thing for us as radiologists, where we can contribute to the diagnosis, are discussing the pelvic and abdominal involved veins, the hemodynamic abnormality, and if we can see any other underlying etiology, if there's some sort of compression or other cause that we can diagnose on imaging. This paper, also this other paper that came out in 2023 is really helpful, and it goes through the update and the terminology, the diagnosis and the treatment, and goes through the different modalities. I really like it as a resource because it goes through some protocols and recommendations and some numbers of what dilated actually means, and then some of the pros and cons of using each modality. So for ultrasound, it's really nice because it's quick, it's accessible, it's good for vascular evaluation. It's one of the techniques that you can do when a patient is standing, which is often the cause. If a woman is having pain while she's standing, or a man having pain when he's standing, then it's an important time to evaluate that symptom with ultrasound. So it's a convenient way to see if the position is a cause. For CT, it's nice because you can see the anatomic detail and possibly the cause of obstruction if there's a compression situation going along with it, but it's a little bit limited because of that supine positioning. And then MRI. I really like MRI because there's a lot of opportunity for time-resolved vascular imaging to go along with it. And then also, if the cause of pain might be something else, such as endometriosis, we might be able to diagnose it in the same exam rather than need another exam. And then, of course, venography is still the standard of care. And oftentimes, regardless of what we do with other imaging techniques, they're going to take them in there and treat the patient with venography and be able to see possibly a reflux or other causes at the same time as they are able to do treatment. They being interventional radiologists. Okay, how many of you guys are interventional radiologists? Yeah. Okay, great. So this is another great paper and resource that I wanted to refer you to for the imaging appearance and non-surgical management of pelvic venous, just say disorders there, close your eyes and scratch that out. And it's very helpful in terms of giving some of these characteristics with ultrasound and MRI that you might want to take a look at later. Okay, let's get to the cases. So the first few cases are going to be all testicular cases that are going to make you always want to look up with your ultrasound probe and make sure that you see why there's a varice on the left. So this is a patient that with Valsalva had a dilated vein with varicosities, and then we go up and we look and you can see that there's vena cava compression by a large mass. This is another patient with a 70-year-old with a right palpable mass with right-sided varicoceles, so it's not always on the left. And then this patient also had a quite large liposarcoma compressing the inferior vena cava and causing the varicosities. This is a 55-year-old with scrotal swelling. This is on the left side. And you can see that there's metastatic colon cancer with multiple masses and abnormal lymph nodes throughout the abdomen, compressing the left renal vein. There's additional issues with thrombus and whatnot, but the issues are the compression of the veins by the additional metastatic findings within the abdomen. For scrotal varicoceles, we're looking for vessels that are greater than 3 millimeters. They increase in size with Valsalva. It's usually left-sided, greater than right. It's bilateral in 40% of men. And it can be associated with testicular atrophy, and this is an absolute indication for a varicocelectomy. This is a 20-year-old with a left palpable mass, so a young gentleman coming in. And then we go up and we look at the kidney. This is obviously quite abnormal for a kidney. And then unfortunately, this gentleman had a rather large papillary renal cell carcinoma causing his findings in his testicle. This is an 18-year-old with a palpable mass on the right that also had similar issues. Male infertility. Ultrasound is very important for evaluating male infertility and specifically looking at varicoceles. It's quite simple to do. Up to 64% of infertile men have atrophic testicles. The normal testicular volume is 15 to 20 milliliters. It can also be related to blocked ducts to the prostate. The association with testicular malignancy is 0.5% compared to, so it's 1 out of 200 compared to 1 out of 20,000. So let's move on now to pelvic pain in women. There has been sort of a campaign over the last 10 years, which has really, I think, led to the change in us calling this pelvic congestive syndrome to a disorder, that there are things in the pelvis that can cause pain that can be treated and reduce symptoms for patients that are having pain. This is a 45-year-old who had a prior hysterectomy, and she had new vascular bleeding after intercourse, and she had an engorged varix in the hysterectomy bed. She went on to venography, and they were able to embolize her left gonadal vein where she had a dilated vessel and reduce the symptoms. This is a patient here where you can see compression of the left renal vein, presenting with nutcracker and like a little bit of compression here of the iliac. That was also likely the cause of her symptoms. But the compression of the left renal vein is quite dramatic. This same patient ended up having collaterals. So this 4D flow stuff's pretty cool because you can see the vascular flow going this way, and you can see it actually going retrograde on the left. So that's not normal. And this is part of the symptoms of what was going on with the patient. So it's not only that you have reflux in gonadal vessels, but you can also have reflux into the lumbar vessels. This is a 20-year-old female with pelvic pain with compression of her left iliac. And here you can see the symptoms. And then the 4D flow is super cool, where you can see the decreased flow in the left iliac vein from compression of the right iliac artery. And, okay, so before I show you the next image, I want you guys to look closely and notice that this patient has situs. So that's a liver over here, okay, inversus. So that's a liver over here. So when we look at the next picture, it won't be so crazy, and you'll be like, what's going on? So everything's going to be flipped. And so she has a very large fibroid here. But you can see that her right iliac vein is being compressed by her left iliac artery, and the fibroid is compressing the right iliac vein here. And this is, was easily evaluated on multiple modalities. But it's kind of nice that you can see the reflux here. These are tiny. Can you guys see the tiny little arrows? Tiny little arrows going in the wrong direction. Okay. Here, I really like time-resolved imaging, and so we use Disco with our vendor to be able to get really fast time resolution. We're looking at about 15 seconds, and being able to actually see reflux down the left gonadal vein before having drainage come up. And so this is helpful for our IR colleagues before they go into the operating room, that they can see that this is probably the cause of the patient's symptoms and can help them prepare for their procedure. They have a protocol of 17 phases. We've just published an article, not this one, this is the original description of the technique on pelvic venous disorders and looking at pelvic of left gonadal reflux. with this protocol, and it is helpful. In conclusion, imaging helps in the evaluation of pelvic congestive and compressive causes. Many are treatable, so please do your best to help your colleagues that are planning for treatment and help men and women out there that are symptomatic. Remember, not every patient that has the imaging findings necessarily have the disorder. The disorder needs to have symptoms as well as the findings. Please reach out to me if you have any questions. I'd be happy to hear from you. I'm sorry that I had the mix-up. I have 2 talks within the same hour right now, so forgive me. Does anyone have a question before I run off? If not, email me. I hope you guys all had a great RSNA, and we'll see you next year.
Thank you. All right, that was awesome. Next up is Dr. Kevin Kalis, and he's going to be speaking about renal artery imaging.
All right. Good morning. I'm Kevin Kalis. I'm coming from Duke, and I'll be talking about renal artery imaging. I added this tagline here, beyond atherosclerosis. So that's not really what we're going to be talking about today. I think that's something not, by all means, it's very important and very common, but I think it's just so common that we see it on a day-to-day basis. I'll kind of go a little bit beyond that, maybe give a little more interesting and kind of sexier cases just to finish off the week. So what are we going to talk about today? So explore the various imaging modalities and techniques for imaging renal artery pathology. Just given the time constraints, I think talking about renal artery imaging protocols and MRAs and all that sort of stuff is probably a lecture unto itself. So I'll kind of go over a multimodality approach, but not really go over the nitty-gritty of protocols unto themselves. And then we'll recognize vascular and parenchymal findings and features of non-atherosclerotic renal artery pathologies in natives. And then towards the end of the case, I'll talk about transplant kidneys. So really, this is going to be a case-based approach, so lots of pictures, little amount of words. Going over a spectrum of renal artery pathologies. So we'll go trauma, dissection, vascular inflammation, and transplant complications. So kind of go show a case, highlighting the topic, say a few blurbs, and show some related cases, and then we'll move on. So let's get into it. I'll leave these up just for a couple seconds. I think just by the history alone, these are probably quite obvious. So very busy case here, made even busier by, let's just say, a number of arrows here. So just starting centrally, we can see a lot of blood products, namely about the aorta on the screen left image. I'm not really showing the renal vasculature, but pretty much in the vicinity and kind of hugging the renal vasculature. On the right, we see a kind of posterior perirenal hematoma. Going to the middle image, really just highlighting the fact that we have some segmental infarcts in the upper poles of the kidneys on both sides. And then the screen right image, really just showing the actual renal vascular pathology unto itself. So we see a pretty sizable upper pole medial infarct here. And this segmental branch with the dotted arrow, as opposed to the segmental artery feeding the rest of the kidney or the lower portion of the kidney that's been thrombosed, kind of feeding or not feeding the infarcted kidney. So this is consistent with segmental renal artery injuries, which would constitute an AST grade 4 injury. So the only thing I want to highlight here is just the AST criteria for renal trauma. Obviously, this is a 5-point scale. I'm only showing points 4 and 5 here because that's really where the vascular findings come into play. So I've highlighted kind of vascular the findings here. So really the take-home points for grade 4 is segmental renal artery. I'm not really going to talk about veins, but vein also constitutes in here as well, or evidence of active bleeding. And then just extending that to grade 5 is really something involving the entire main renal artery or essentially the entire kidney itself. So you see the word vascular injury thrown in here a couple places. So what do we mean by vascular injury? And I'll show cases of this in just a second. Really, we're talking about pseudoaneurysms, AV fistula, and active bleeding. So we just showed grade 4 with a couple segmental injuries. This is just to round it out and show the devascularized kidney, which is an AST grade 5. So just starting more centrally and going to the renal vasculature, we see the right renal artery just beyond its origin is essentially occluded. This is probably a thrombosed dissection. With the small arrow there, we see a little bit of contrast kind of sneaking its way through into a segmental artery, but for all intents and purposes, this renal artery is out. And then, therefore, the entire kidney on the right is essentially out as well. With that little arrow on screen right, there's a little bit of a kidney still hanging on, but I think for all intents and purposes, we can call this a devascularized kidney grade 5. So a couple cases here, not necessarily trauma per se, I guess depending on your definition for trauma, more iatrogenic. This is a case of partial nephrectomy, but really just to show the gamut of other other kind of categories of renal vascular injury I mentioned earlier. This is a renal AVF. So we can see with just following the vessels, kind of in order of blood flow, we see a nice well-opacified artery on a CTA image. On the solid arrow there, kind of in this hilar portion of the kidney, we see a dilated tubular structure that's essentially, this is the same enhancement as the arteries, and then we see too early flow into the renal vein. So that's the essentially contemporaneous flow into the right renal vein is with the dotted arrow, and that's contrasted to the small arrow on the left. That's the normal kind of physiologic or expected enhancement to the left renal vein, so way too early. So this patient for repair went on to angio, and this is just to show kind of in real time. We see contrast going into the artery, kind of making a beeline towards the renal vein, skipping the kidneys, and going straight back into the renal vein and back up the IVC. So it's another case of partial nephrectomy. I feel like I'm kind of ragging on urology right now, but trust me, I'll get to my own whoopsie doodles in a second. So this is a case also partial nephrectomy. Probably the most pronounced finding here is posterior to the right kidney. Pretty sizable perinephric hematoma, but the vascular injury I've noticed with the solid arrow, that kind of rounded structure, pretty much having the same enhancement as blood pools. So in the setting of trauma or something iatrogenic, when you see something like this is essentially a pseudoaneurysm. So this patient also went on to angio for correction of this. You can see they've already been embolized at one point in time, or either before this or at one point in this procedure, but really just the finding here, you can see the filling kind of on the lower portion corresponding nicely to what we see on the CT. So also just to round it out with active bleeding, nothing really special about active bleeding with respect to the renal vasculature or renal arteries. It's like active bleeding anywhere else in the body, which is a good case here. On the screen left image, you can see, again, pretty sizable hematoma with the actual vascular finding with the arrow there. We can see a little bit of a blush of contrast, good form with any sort of suspicion for active bleeding. You get a slightly more delayed phase. On the middle image, we can see that contrast kind of squirting and pooling very nicely. And the screen right image, this wasn't necessarily done to confirm the active bleeding. I think we have that on our first two phases here already, but we can see the contrast kind of diluting out into that hematoma. Really just good form when you have a perinephric collection hematoma in the setting of a pretty bad renal trauma. You want to just make sure there's no collecting system injury, and there is not a collecting system injury on this case. With the dotted arrow, we're looking for that kind of concentrated contrast in the collecting system. We don't see that density of contrast pooling into the hematoma, so vascular injury, no collecting system injury. Moving on to our next case. So again, having kind of history maybe gives this away, but that's okay. So this is a spontaneous renal artery dissection with infarct. The actual vascular finding itself, admittedly on this image, is a little bit on the subtle side. So on the screen right image, we see a pretty good sizable segmental infarct in the upper pole of that right kidney. So following the vessels, you can see here, I think I put the arrow with the most pronounced part where that dissection becomes near occlusive, but you can see here kind of this hypoattenuation along the course of pretty much a majority of the vessel. So that's probably their thrombosed dissection, that right renal artery. Just a couple of talking points about renal artery dissection. So just first to kind of consider etiology and risk factors and who gets these pathologies. So I mentioned I kind of did show dissection before, but traumatic and iatrogenic, we commonly see this. Extension from an aortic dissection, whether type A and or B. I said I wasn't going to mention atherosclerosis, but atherosclerosis does is a risk factor for renal artery dissection, and the underlying vasculopathy. So I had the case here just with Ehlers-Danlos, so other connective tissue disorders, Marfan's, Loeys-Dietz, things like that. FMD, which is maybe not connective tissue disorder per se, but just kind of underlying vasculopathy, which I'll show a case of in a second. Imaging, I think we're pretty comfortable with the imaging findings here, pretty much extrapolated from larger vessel dissections, which we see much more commonly. So with these, you can actually see a discrete dissection flap where you see a discrete dissection flap and a true and a false lumen. I think anecdotally with these smaller vessels, whether in the body or kind of head and neck, we're more likely to see partial or complete thrombosis of the dissection. Sometimes that discrete dissection flap finding is not too satisfying. As I've shown here, main complication of this is renal ischemia, which can be anywhere from just kind of some developing hyperperfusion to frank infarct, which I've shown a number of times already. And then when left untreated or uncorrected, these can just develop renal atrophy and scar, either segmentally, or if it's the whole kidney gets atrophied. And then a potential future complication of this is aneurysm and rupture. So just another case, not sure quite the history of this one, but this is another spontaneous renal artery dissection with infarct, a little bit more extensive on this one. So we can see the right, on screen left, the right renal artery dissection being pretty much completely thrombosed. We don't see that discrete dissection flap on this one. Moving over to ultrasound, we see pretty much no flow within the majority of the kidney. Maybe a little bit of couple dots there in the lower pole of the kidney. I'm not sure if that's artifact or real. We do have a little bit of flow in the lower pole in that screen left image. And on the parts that we're able to get a little bit of spectral flow on in the interpolar region of the left kidney, that flow is not quite robust. We have a little bit of delayed upstroke, decreased velocity. Essentially, a tarvis part is commensurate with the fact that we have a pretty significant upstream obstruction from their thrombose dissection. So it's the same case. Again, screen left image, this was a presentation image where a majority of the kidney is infarcted due to that spontaneous renal dissection. I'm sure we've seen cases of this. If they can't correct the renal artery or can't reperfuse it properly for whatever reason, the kidney stays. So we can see that lower pole is still doing its thing, and maybe even a little hypertrophied a little bit, but unfortunately, that majority of that kidney is now atrophic and probably not functioning too well. Aortic dissection. So again, this is probably what at least I probably most commonly see in the non-traumatic setting is extension of aortic dissections into the renal artery. So again, starting with the kidney and moving backwards, we see a pretty sizable infarct in that right kidney. This one we actually see the discrete dissection flap within the right artery, a discrete true and a false lumen, and then following it back up, it goes into the aorta, and then where did this all start? Their type A dissection going from the root into the arch into the descending thoracic aorta. In real life, probably we'd see the aortic dissection and hopefully not miss the renal thing. But again, it's not just primary renal artery dissections by all means. So this is a case, again, just kind of rounding out in terms of vasculopathies. This is a case of fibromuscular dysplasia. Again, kind of just showing dissections and kind of how they can be associated with aneurysms. Admittedly, this is a little bit of a subtle case, but this is just showing here on the screen left, a short segment dissection, a little bit of aneurysm, a little fusiform dilation of that mid-renal artery. So whenever you see, I think I kind of like this, whenever you see a renal artery dissection or pathology, especially a dissection, I think it's tempting to say, dissection, that's curious, and then move on. Do take a look at also, like, why do they have that? Because it's kind of weird to just have an isolated renal artery dissection. Admittedly, I don't move too much into the head and neck, but FMD number 2 location is carotid and vertebral, so this patient also had a kind of subtle in their right internal carotid artery, short segment dissection, a little bit of dilation. And then number 3, celiac, a little bit more pronounced. You can see a dilated, beaded appearance, a little bit short segment dissection as well. So this is a nice, albeit subtle case of kind of multivessel territory involvement of their FMD, explaining why they have that renal artery pathology. This one is not dissection per se. I think it's a cool renal artery related case that I just had no other place to put. But we do have multifocal infarcts, right upper pole, left lower pole. I'm not showing the renal vasculature. The renal vasculature, let's just take my word for it, was normal. When you have that kind of small territory of infarcts, it's usually probably not going to see anything in the renal vasculature since they're such small segmental vessels. Renal vessel is normal. Trace the upstream aorta. It was normal. Take a look at the heart, and there's a big Goomba there on the mitral valve. But this patient was bacteremic, so bacteremic plus thing on the mitral valve plus infarcts. That's endocarditis. Period. End. You can make the call without the echo. Moving on, and just going a little bit quicker here. Left upper quadrant pain. Again, the renal artery finding itself is pretty subtle, but we have infarct to the left upper pole of the kidney, partially visual on this is the spleen there. So this is a case of vasculitis. So this patient actually had 2 renal arteries. The main, or the larger caliber renal artery is actually normal, which is why a majority of the kidney is normal. And then the accessory renal artery has a little bit of eccentric kind of soft tissue. That's actually their vasculitis. I have the screen right image here just to show this is more of a systemic median vessel vasculitis with a pretty pronounced inflammation about the celiac. You can see that soft tissue thickening, a little bit of enhancement, which was also affecting the splenic artery, probably more so, which is why a majority of the spleen is gone. So in terms of vessel inflammation, we talk about inflammatory, which is kind of the rheumatologic spectrum, or infectious, which can be a primary medium vessel process, or it can be a large vessel process extending into the renal arteries. Imaging, this is kind of just generic for vasculitis. We're looking for wall thickening, enhancement. I like MR for vasculitis. It's maybe not quite as helpful on the medium vessels, just owing to lower spatial resolution in smaller vessels, but I think it's still useful. If you have MR, good quality T2, you can see wall edema, which is what I'm showing here on the image there. Diffusion-weighted imaging, again, I don't know how useful that's going to be for medium vessels. There's not great data specifically on renal arteries for this, and I really like subtractions, assuming they're of good quality, to really see that inflammation enhanced. If you have PET, of course, FDG uptake. Complications can be aneurysm, dissection, stenosis, or rupture, and then end-organ ischemia, which I've shown time and time again. So this is just a case of large vessel vasculitis involving the renal arteries. So this is a patient with Takayasu's. So we can see on the screen left image, pretty circumferential involvement of the aorta extending into involving the left renal artery. Screen left or screen right image. So I've filmed cases of frank infarct and frank dead kidney. This is a little bit more subtle in the sense that it's involving the left renal artery. So not infarcted per se, but definitely having some perfusional effects on that left kidney. This is a case of mycotic aneurysm, really just to show how these things can blow up really fast. So for mycotic aneurysms, the main concern is aneurysms or pseudoaneurysms and then rupture risk. So on presentation, they really had a no portal venous phase image, but the renal artery itself, was normal, just a lot of inflammation. 6 days later was the next time we saw them with contrast-enhanced imaging, this time with MR, and you can see it's completely blown up. Not popped quite yet, but very large pseudoaneurysm of that left renal artery. And then finishing up with some transplants. Again, I'm just going to go a little bit quicker just to stay on time here. So this is a relatively bread and butter case of transplant artery stenosis seen at ultrasound. So just going in the order here, we're sampling the upper pole intrarenal artery. You can see a pretty classic case of a tarvis partus waveform, suggesting something more upstream to that is having a significant stenosis. And then the anastomotic image and then the internal iliac artery image, we see elevated velocity. It's not too high, but 250 at the anastomosis. But really when you compare it to the upstream iliac artery, that's a pretty hefty gradient, 250 to 1 or about 2.5. This patient went on to get imaging. I just really wanted to highlight here some kind of like renal safe methods of doing renal artery imaging. Our colleagues in transplant really do not like iodine, their patients getting iodine. So this is an example where ferrum oxytol is useful for MRA. So you can see, actually you can't really see the origin of that transplant renal artery. It's a pretty high grade stenosis both on the source images and the MIPS. And this patient went on to angio to try to open that up. They didn't do CO2 injection for the entirety of the procedure, but especially to kind of get bearings and kind of lay the land, they opened up with CO2 to just reduce their iodine contrast dose. So complications, so a stenosis, pretty much what I said. Elevated velocities, our magic number tends to be 200, especially with that gradient with respect to the internal iliac artery, and then downstream spectral broadening going on to tarvis partus. Thrombosis, the extreme aspect of that, basically that's a surgical emergency, so dictaphone down, phone up sort of situation where you see no flow within the renal artery and the parenchyma. And then there's other complications generic to anastomoses, pseudoaneurysms, AVFs, which tend to be post-biopsy. So this is that case of renal artery thrombosis, grayscale ultrasound, color Doppler ultrasound, seeing no real flow within the renal parenchyma. CT, we see no flow within the parenchyma, or no enhancement of the kidney, and we see an abrupt cutoff of that renal artery. This patient actually had an end-block transplant, so you can actually see the normal kidney paired with the not normal kidney. Torsion, this is just a weird case I've only seen once. Technically constitutes a renal artery stenosis. You can see at baseline the kidney's more on the left as a part of a dual kidney panc transplant. At presentation, flipped over to the right or flipped over to midline. Then you can see on that movie image here, basically it's kind of like essentially it's a torsion, so you can have twisting of the vessel causing narrowing of both the artery and the vein. Anastomotic pseudoaneurysm really looks like a pseudoaneurysm anywhere else in the body. Just keep in mind that these are surgical anastomoses that can have pseudoaneurysms. Pseudoaneurysms post-biopsy, so this is a grayscale ultrasound where we see a cyst in quotations. Put color on that thing, we can see that's filling with color, to and fro flow. They got a CT where it fills, just like we saw in that trauma case. And this one is my doing. So AV fistula, we can see an area in that medial aspect of the kidney, color alacing, pretty turbulent flow. Look back at the prior report, see my name on the bottom, I say, oh fudge, and I pull up the image. That's what did it. All right, so what are some take-home points? I'm sorry, I'm running a little bit over. So beyond the fact that I'm a borderline competent interventional radiologist, we saw a wide spectrum of critical pathologies that exist beyond atherosclerosis. And then, as I tried to show in indirect fashion, multiple imaging modalities can be very complementary in diagnosing the spectrum of renal artery pathologies. Thank you.
Great. Our last talk of the session is Dr. Avnish Gupta, and he's going to be discussing gastrointestinal bleeding. Just for them to see, I really need to pull it down to us.
Okay. Thank you. All right. Thank you for the introduction. So I'm going to be talking about acute gastrointestinal bleeding, and this is really, I'm focusing more on an algorithmic approach. So learning objectives are essentially to understand the algorithm, not as much the imaging findings, but really more the algorithm, how the different imaging modalities fit in with endoscopic techniques and so on, to understand the advantages and disadvantages of each diagnostic tool, and most importantly, really to understand why a particular GI bleeding imaging study was requested and how it fits in with the overall clinical scenario. So I'm a diagnostic radiologist. We know that there's several interventional radiologists, but it's pretty uncommon for someone to ask me specifically, what should I do next? Should I do a CT angiogram? Should I do some form of endoscopy? Should I do a nuclear medicine study, and so on and so forth? So I think a lot of diagnostic radiologists are probably in the same boat as me. We just read the studies that are on our list without necessarily knowing or being consulted on as far as studies or just workup that may have preceded or why we're doing a specific type of imaging study. So I'm going to kind of gloss over this. And we know that gastrointestinal bleeding is a very important problem with costs and morbidity, mortality, and so on. So upper GI bleeding typically is mostly diagnosed with endoscopy. So that's a very important point. However, imaging can play a complementary role in some situations. So it can be important, but mostly diagnosed with upper endoscopy. As far as lower gastrointestinal bleeding, that imaging is much more important in that situation. So you have different like endoscopic techniques, but imaging is extremely important. So it's helpful to understand a few definitions because that'll can help to narrow differential diagnosis a little bit. So an overt GI bleed is one that's clinically apparent. So it's very obvious the patient is clearly bleeding clinically. You don't need special tests to know that the patient is acutely bleeding. Hematochezia, hematemesis, for example. Occult GI bleeding is different. So it's not clinically apparent, but the patient may only present with a positive fecal occult blood test or maybe an iron deficiency anemia or something like that. Whereas obscure GI bleeding is bleeding where no clear source is identified. An upper endoscopy was performed, a lower endoscopy was performed, no clear source. That usually narrows it down to the small bowel. Okay, so we all know that the upper GI tract includes the esophagus, stomach, and the duodenum to the ligament of Treitz. And importantly, that accounts for about 3/4 of all acute GI bleeding cases, whereas the lower GI tract is beyond the ligament of Treitz. And it's important I think, to further subdivide the lower gastrointestinal tract into small bowel and colon because there's different workups and differential diagnoses based on those two different parts of the lower GI tract. So the differential diagnosis for acute GI bleeding is very broad, and this list doesn't even scratch the surface. The list is miles and miles long. So it can be very intimidating. However, I just want to point out that the majority of GI bleeding can be really narrowed down to a few diagnoses. So for upper GI bleeding, 3/4 of those are due to peptic ulcer disease. So if you remember that, then you're going to be right 75% of the time. For lower GI bleeding, if we're looking at the colon, diverticuli or diverticular disease accounts for about 2/3 of all cases. Whereas for small bowel bleeding, it's mostly inflammatory bowel disease in a younger population and angioectasias in an older population. A few additional caveats. So if in a cirrhotic patient population, about 60% of those cases of upper GI bleeding are due to varices. And we all remember from medical school that an upper GI source is responsible is the cause of lower GI bleeding in a not insignificant fraction of cases, about 15%. So always just remember that. So these are the various tools that we have at our disposal. So there's endoscopy, including EGD, colonoscopy, and then capsule. We have catheter angiography, we have CT, and we have nuclear medicine. I just want to point out some minimal bleeding rate thresholds. So CT is about 0.3 mLs per minute, and in fact, newer data shows it's actually quite a bit more sensitive, like even 0.1 mL per minute or even lower, using mathematical modeling and dual energy CT techniques. Scintigraphy is the most sensitive, whereas catheter angiography is about 0.5 to 1. Just to give you a little bit of context, just remember a teaspoon is 5 mLs. So we're talking about extremely small quantities of blood that are in the 0.1, 0.05, 0.1 ml. So just think of that compared to something that you're familiar with. Okay, so a workup of upper GI bleeding, we talked about this. So upper endoscopy is the first line for sure, and it accounts for almost all of the cases of bleeding diagnosis. So there's some notable exceptions, like for example, if an EGD is contraindicated for whatever reason, coagulopathy and so on, or if there's post-surgical anatomy like this Roux-en-Y gastric bypass. Very difficult to do endoscopy in this situation. So now we know that there's multiple tools. Now we have to understand when is imaging indicated for upper GI bleed. So we look to the ACR for help. So the ACR appropriateness criteria defines 4 specific scenarios. First, if EGD finds the bleeding source but hemostasis fails, you're then left with angiography with the intention to treat. Okay, so that's really important. Secondly, if EGD finds the bleeding, finds that there is bleeding, like a blood clot in the stomach, but doesn't identify the bleeding source, now you're looking at a diagnostic method, like either catheter angiography with the intention to treat or CT angiography with the intention to pinpoint a possible source of upper GI bleeding. Third, if EGD is negative, then you can go to angiography or CTA, or if EGD is contraindicated, then you can also go to imaging. Here's just an example. It's usually pretty straightforward and pretty clear to make the diagnosis, but in this particular instance, this patient had acute hematemesis and anemia. The CTA was performed, but hemostasis failed, and you can see there's a large amount of extravasation into the lumen of the duodenum. Patient went on to catheter angiography and was successfully coil embolized. Another patient, similar clinical situation, but this time the patient was on Coumadin. And so the upper endoscopy was contraindicated or deferred due to the anticoagulation. So a CTA was performed, and you can see there's, along the greater curvature of the stomach, there's a small pseudoaneurysm, a big surrounding hematoma. On delayed phase imaging, it gets a little bit slightly denser. The patient was eventually taken to angiography, which showed a small pseudoaneurysm, which leaked with more of a delay, and this was subsequently coiled, treated successfully. As far as the workup of lower GI bleeding, it's as I mentioned before, imaging plays a much greater role. So if a colonic source is suspected, colonoscopy has been in the past considered more of a first-line diagnostic test, but really it's not always feasible, particularly in the emergent setting. And this is where CT tends to shine. It's very easy to do, it's quick, it's readily available, and so that's generally a first-line diagnostic method. If a small bowel source is suspected, then that's where you're looking at capsule endoscopy. So that's generally the first line. But if the capsule is contraindicated for whatever reason, strictures or patients unstable or whatever, that's where CT is very helpful. Either CT enterography if you're looking for IBD or a mass, or CT angiography if the bleeding is brisk. So we turn again to the ACR appropriateness criteria, and they define several clinical scenarios. So first, if the patient has clinically apparent bleeding, but they're stable, this is where CT is quite often performed as the first line, and it really shines in this scenario. Colonoscopy really wouldn't, it can be done certainly, but CTA is usually the best bet. If the bleeding is clinically apparent and they're unstable, you certainly don't have time for a colonoscopy, and that's where again you go to imaging. Other scenarios include if the colonoscopy found the bleed and treatment failed, then you go to angiography with the intention to treat. And conversely, if angiography was done but treatment was unsuccessful, then you can go to colonoscopy. And finally, if you have a clinically apparent stable, if the bleeding is clinically apparent and the patient's stable, and you have a negative upper and lower endoscopy, and you've then narrowed it down to the small bowel, that's where capsule or CT enterography can be helpful. Here's an example of a small bowel mass picked up via CT enterography. Another example, this is an older patient, 85-year-old, with acute lower GI bleeding, showing a tangle of vessels in the distal ileum, which was consistent with bleeding angioectasia, taken to catheter angiography, which showed a bleed and was successfully treated. Another patient, this just to show an example of a red cell bleeding scan. This patient had acute lower gastrointestinal bleeding after a negative colonoscopy and a negative CT, and it shows a very clear bleed. So very sensitive test, very helpful in this situation. Patient was taken to angiography. They found a pseudoaneurysm, which was subsequently treated. Dual energy CT can be very helpful. Occasionally, we will pick up a bleed on a scan that was not performed as a multi-phase scan. So, for example, this one was done with just a single phase, and you see something hyperdense in the right colon. Could it be a pill? Could it be something ingested? Who knows? Virtual non-contrast imaging shows that resolves, but it shows up on iodine density map. Patient was taken to angiography, and a bleed was pseudoaneurysm was confirmed and was subsequently treated. So, in conclusion, we made several points, and I haven't really focused much on the imaging as much the algorithm and kind of how the imaging fits together with the with all the diagnostic methods. So for upper GI, it's almost always diagnosed with endoscopy, but imaging can be helpful in select cases. Lower GI bleeding, imaging can be more helpful. In the small bowel, you're looking at IBD and angioectasias. In the colon, you're looking at diverticulosis. And so my ask of you is, when you're reading a diagnostic study and a study pops up on your list as a CT angiography or whatever, in the assessment for GI bleeding, think of why that exam was ordered in comparison to other available diagnostic options. And in particular, look in your electronic medical record and see what diagnostic methods or studies, whether they be imaging or non-imaging, preceded that study that you're looking at. And with that, I thank you for your attention.
Thank you. And that concludes our session. If you have any questions, since we're running out of time, I would recommend for you to come up to the front and chat with our speakers here. Otherwise, just enjoy the last few hours of RSNA 2024. Thank you.
Well, yeah. I mean, they're just trying to